Hi, everyone. Welcome back to another PVACCS talk. We've got a very interesting topic tonight. My name is Matt. I'm the co-host alongside Anthea. We've got a very special guest, Professor Tuxson, on tonight from the Alfred. I guess we should take it away, respiratory failure. So tonight's event, just like always, try and get it done in 60 minutes. We're going to cover the pretty pertinent topic of respiratory failure. Of course, we're going to have question time. Feel free to ask questions as you feel throughout. Otherwise, we've got a link for you to engage with us through. So that's the Slido link right there. Feel free to use the QR code. We've got our sponsors. Obviously, these events can't proceed without them. We've got Doctor On Call and Amboss, both sponsoring us for this event. Very appreciative to have them. Obviously, Amboss is very keen to help you guys out, and they're providing you with a discount and a free trial here. So be sure to scan that when you can. And the same goes for Doctor On Call. I'm sure if you're regular, you've heard the spiel. So respiratory failure and our special guest, Professor David Tuxson. So Professor David Tuxson has a plethora of experience, both a respiratory and ICU physician from the Alfred. He has pretty much every single qualification under the sun, and I guess I'll just let him take it away.
Thanks very much, Matt. And I'll just share my screen. And there we are.
Thank you very much.
Okay, well, as you already know, the topic for today is respiratory failure, and we're going to go right back to the beginning of that and then take it all the way through to mechanical ventilation in intensive care. Feel free to ask questions through the talk if you wish, or at the end or online. I'm happy to be questioned at any stage. Now, you're probably all aware of the definitions of respiratory failure. There's type 1 and type 2, or hypoxic or hypercapnic respiratory failure. So type 1 hypoxic respiratory failure has been defined as a PO2 less than 60 on air. And usually in this condition, the CO2 is normal or low when you respond to the hypoxia by increasing breathing. And the second type is hypercapnic or type 2 respiratory failure or ventilatory failure. And that's defined as PCO2 greater than 50, but it has to have a low pH with it. A PCO2 less than 50, more than 50, with a pH that's normal or above normal might be hypercapnia appropriately for a metabolic alkalosis. So it's got to have a pH below normal range as well as a CO2 over 50 to be ventilatory failure. And of course, it's very seldom pure because one pretty much always leads to the other when it gets bad enough. So hypercapnic respiratory failure will eventually lead to hypoxemia, and bad hypoxemic respiratory failure can become complicated by hypercapnia. But on presentation to hospital, there's usually one or the other is the leading player. Now, I want to talk about ventilatory failure first and give you some concepts there. And this is basically where there is an imbalance between your ability to breathe and your load to breathe. So your ability to breathe depends on your muscle power and also on your chest wall geometry. So for example, if you're very hyperinflated, your respiratory muscles can be very strong, but they're very ineffective if the chest is already fully expanded. Or if there's severe kyphoscoliosis, the chest wall geometry very much limits movement. Your load to breathing is respiratory impedance, which I know that you all know is the combination of impedance, of compliance and resistance. So the impedance to breathing could be from a stiff lung or chest wall or from airway obstruction. Both of these add to the load of breathing. And the other load that's not always recognised is the minute ventilation requirement. So the minute ventilation requirement increases for example, if you've got a high CO2 production, as happens when you become sick, or if you've got a big dead space. So let's look at these a bit further. So respiratory drive or losing respiratory muscle power can be reduced respiratory drive. And this is quite different to the other lesions. Here, with this, you are not trying. So that can be if you're narcotized, over-sedated, or you've had a drug overdose. And rarely, it can be due to a stroke or a tumor affecting the respiratory center, but that's most uncommon. And it can, again, rarely happen after a head injury, but usually when you stop breathing after a head injury, it's because you have coned, you've become brain dead. So the respiratory center is squashed by the brain herniating through the foramen magnum. So most commonly, respiratory drive failure is due to narcotic sedation or drug overdose in the acute setting. Now, as we've said before, alkalosis reduces respiratory drive, trying to fix up the pH. That's a metabolic alkalosis, induces you to allow your CO2 to go up so that you become less alkalotic. So that is a compensatory mechanism, not a failure, which is why respiratory failure has to have a high CO2 and a low pH. Now, going further down the line, you might get respiratory force failure because of a neuromuscular lesion, which can be anywhere from the spinal cord, paraplegia, a neuropathy or nerve trauma, or a neuromuscular junction failure like myasthenia gravis or neuromuscular blocking agents, or from a muscle weakness such as a myopathy, or sometimes severe wasting illnesses. And of course, you can get force failure where the force cannot be effectively translated into effective expansion of the chest. So severe kyphoscoliosis, ankylosing spondylitis, where it affects the costochondral junctions, a flail segment, which is where every time you take a breath in, the flail segment gets sucked in, preventing lung expansion, or just hyperexpansion of the lung fields due to, for example, emphysema. So when the diaphragms are already down as low as they'll go and the chest wall is at the maximum, it's very hard to, despite muscular effort, get any more breath in. So that's force failure. Now, and of course, respiratory failure can be from excessive load to breathing. Now, we already said that it can be from a stiff lungs or chest wall. So pulmonary edema, ARDS, pneumonia, acute causes of stiff lungs, or pulmonary fibrosis can cause ventilatory failure, or if you've got a very distended abdomen, the abdomen is part of the chest wall. In other words, the abdomen pushes the diaphragm up, and that's part of the outside or one of the surfaces opposing the lung inflation. So that's the most common cause of ventilatory failure, morbid obesity, and so on. So, of course, it could also be airway obstruction as a load to breathing. So this is compliance, and the next one is load to breathing, is airway obstruction, resistance. So this can be lower airway, which is asthma, an acute condition, or chronic obstructive airways disease, a more chronic condition. Or it can be upper airway obstruction. It can be an endotracheal tube that's too small, a foreign body in the airway, or trauma or tumor in the airways. And the other thing you can get is increased CO2 production. And that is, we all get that when we exercise. And often when we sprint at the end of our jog, we get anaerobic metabolism and a huge lactate load, which puts your CO2 right up and makes you very short of breath. Usually not hypercapnic, but I guess it could at the end of severe exercise. But more importantly, in critically ill patients, when you become hypermetabolic in response to critical illness, and this is part of your body's way of hastening its healing. We get a fever to improve metabolism, which increase metabolism. It's like a chemical reaction. It goes faster. That promotes better macrophage action. That promotes better antibiotic action and faster new cell growth. And so it's an adaptive response to get a temperature. And part of that is you have hypermetabolism induced, and that involves, of course, more oxygen delivery. So there's more supplies to the injured tissue and more CO2 production. And that happens after pretty much every major illness. And we also know, so that happens in all critically ill patients, and it can be anything from a 25% increase to a 100% increase, which of course doubles the amount of breathing you have to do. And lastly, we all want to feed people enough, but if we actually overfeed people, particularly glucose, that results in glucose production, glucose conversion into lipid, into fat. And we all know if we eat too much sugar and have too much soft drink, we get fat. And that's exactly what happens to our patients if we overfeed them. They have to get rid of that sugar somehow. And one of the ways of doing it is to turn it into fat. And turning sugar into fat has a very high CO2 production associated with it. And that's, I don't know if you've ever felt puffed after a meal, that could be converting your sugar into fat, and that's what happens to critically ill patients. And the last bit of excessive load to breathing is where there is an increased dead space. Now, dead space can be increased. Dead space is obviously something that's ventilated and not perfused. That means the air goes in and out of the lung, but there's no circulation to that bit of lung. So that bit of breathing going in and out doesn't get rid of any CO2. So you have to put more breathing into the other bits of lung, because when you've got dead space, the airways don't adjust for it and just send. For example, if you've got one lung blocked off, the airways don't conveniently say, well, I won't send any breath to that lung, I'll only breathe for the other lung. So that can happen with vascular disease, like a pulmonary embolus, blocking off bits of lung, but it also happens with parenchymal lung disease, such as ARDS and pneumonia and so forth. They all increase dead space. So you can see there's four different ways in which the increased work of breathing, increased load to breathing can go up. And often some or all of these things are present when you get sick. Often dead space is increased, CO2 production is usually up, and you might get a bit of collapse of your lung bases and a bit of a stiff lung. You might get a distended abdomen, and these all increase the load to breathing. Now, that's all the things that can make things go wrong, but clinically, you've got to put it into two distinct clinical patterns. One is won't breathe, that is not interested in breathing, which is ventilatory drive failure, and can't breathe, that is working hard, trying to breathe, but being hypercapnic despite increasing effort and distress. So they're two quite different things. So won't breathe is a ventilatory drive failure, most commonly due to oversedation or too much narcotic or a drug overdose. And sometimes neuromuscular failure can give the appearance of not interested in breathing, whereas actually the person's trying hard to breathe, it just doesn't look like it. So, but we'll forget that wild card there and just look at won't breathe from drive failure. Now, won't breathe, there's not, which is not interested in breathing. So we call this the happy hypercapnic. In other words, he's hypercapnic, but not bothered by it. No overt distress, no attempt to increase ventilation. The breathing patterns are either normal, relaxed breathing appearance, but with a high CO2. In other words, mild oversedation or primary hypoventilation. So it looks okay, but you don't know he's hypercapnic until you do a blood gas. The second breathing pattern is obvious hypoventilation, obvious slow or shallow ventilation. For example, a drug overdose. Breathing rate of 4, hardly any air moving. You can see there's not enough ventilation. And of course, the other end of that spectrum is complete apnea. This can sometimes happen after a head injury or, for example, with full muscle neuromuscular blockade. No breathing at all. Now, can't breathe can be an acute illness affecting the respiratory system. ARDS from multiple causes, including pneumonia, aspiration, multiple fractures, and sepsis and so forth. Or it can be from asthma or a flailed chest where you are trying really hard, but you're not getting there. Or it can be chronic from COAD or kyphoscoliosis. And of course, we see COAD coming in when there's been, for some reason, it's got worse. So it's an exacerbation of COAD. Now, can't breathe acutely it's not yes or no, it's there or it isn't. It's a sequence of events, and you are seeing it at some stage of the process. So the first thing we know is a ventilatory pattern of fatiguing muscles. That means when your breathing muscles get fatigued, you take in smaller breaths because you haven't got the muscle strength to take in a big one. And so to compensate for that, you have to breathe more rapidly. So rapid shallow breathing is the most common pattern that's well recognized of fatiguing respiratory muscles. But there are two other very important breathing patterns that are much more important because they are representative of impending collapse. One is periodic breathing. That is, there's periods of slow breathing followed by periods of escalated breathing. Pardon me. So we notice, if you can see my hand motion, big breathing waves, and then slower breathing, and then all of a sudden, faster breathing. This is what happens with periodic breathing. The muscles get fatigued, but the CO2 is okay. So the muscles say, I've got to have a rest. And so the tidal volume goes down and the rate goes down. So the breathing muscles can have a rest. And the muscles get a rest, but unfortunately the CO2 builds up. And then the respiratory center says, hang on, we're not happy with this. Speed up again. So then the respiratory tidal volume and rate escalate again, and the CO2 comes down, the respiratory center is happier, and the muscles get fatigued and want another rest. So this is a pattern of further down the line of breathing failure, and it's representative, it means impending collapse. And another one is the paradoxical breathing, where we see a rocking motion. So this is usually where the diaphragm becomes fatigued because the diaphragm does all the work and eventually can get fatigued. And in this case, it just has a rest. But so the chest wall takes over and the diaphragm actually moves paradoxically. So if I can show you with my hands, normally, this is chest here and that's diaphragm there. Normally when we take a big breath in, the chest and the diaphragm go up together. But in paradoxical breathing, the chest goes up and sucks the diaphragm in. So you get this breathing pattern like this. And that, of course, makes breathing much more inefficient because half the chest wall efforts are negated by the diaphragm just being sucked in, resulting in a smaller tidal volume. So that also is a pattern of impending collapse. Now, the next phenomenon or the next clinical manifestation of breathing failure, can't breathe, is features of hypercapnia. And that is, we know CO2 is a vasodilator, so you get a warm, flushed periphery, you get a bounding pulse. If the CO2 goes up acutely to over 70 or 80, then you get drowsiness and blunted mentation, and you get a metabolic flap or asterixis. These are all recognized clinical features of hypercapnia. Also, you get a sympathetic response to hypercapnia or breathing failure. This is your fight or flight kicking in. So you get sweating, and tachycardia as part of the sympathetic response. And the other third feature is general features of acute can't breathe failure, and that is anxiety, distress, and restlessness. Now, if you can't breathe, it's like being underwater. If you can imagine not being able to get your air when you're underwater, it's a very distressing experience. And of course, lesser degrees of it make people anxious. It's anxious and distressing. It's not like circulatory failure where getting hypotensive doesn't feel so bad. It's very distressing to not be able to get your breath. So it's normal to have anxiety, distress, and restlessness. And so it's very important that you don't say, oh, gee, you're over anxious. I'll give you some diazepam. You've got to make absolutely sure that there's not respiratory failure there before you sedate a breathless patient, because particularly in certain acute illnesses like severe acute asthma, which is often labelled as being caused by anxiety, there's many public cases where a patient with severe asthma is being labelled as anxiety due to all their respiratory distress, and they get sedated and then they stop breathing. So it's normal to be anxious when you can't breathe. It's not generic or underlying anxiety. Slide not moving on. Let's see. There we are, it went. Now, there is also a time sequence in respiratory failure. It doesn't just start. You're fine 1 minute and the next minute you're terrible. You go through a progressive downhill run as part of this pathway, and it's important to recognise it earlier rather than late. So the first is the compensated phase. So we all have, let's say, plenty of respiratory reserve. In other words, we've got inspiratory muscles that should be able to suck negative 100 centimetres of water, and we only need 10 centimetres of water to expand our normal lungs. When you get sick or have surgery, your work needed to expand your chest will often double, and your breathing muscles will often go down to, say, 60%. But that you've still got, if you're a fit young athlete like Matt, you've still got plenty of respiratory reserve there. In other words, you're down from 100 to 60, your requirement to breathe in is gone up from 10 to 20, but there's still plenty of power left to do it. So the muscle power's down, the load's up, but there's no power imbalance. So you've got normal breathing pattern and your normal CO2, but you've lost your reserve. The next is the decompensating phase. That's where there's a power imbalance is present. Your respiratory muscles adopt a fatigue-sparing pattern, so you have an abnormal breathing pattern, but this will often maintain your CO2 relatively normal. And then finally, frank comes along. So by the time you reach the, you've been failing in steps 1 and 2 to some degree, but you don't reach the diagnosis of frank respiratory failure until your respiratory compensation fails. Failure to excrete the CO2 load, which means you're much closer to the risk of respiratory collapse. In other words, by the time you get hypercapnia as a result of increasing respiratory fatigue, you're getting closer to needing ventilatory support. And you might be a little bit close, or you might be very close. So this is a deteriorating breathing pattern with distress, respiratory distress, and of course, hypercapnia is present. Now, here is a very extreme example of an injured lung. And not all lungs look this bad, but I've given an extreme example. And this is an acute lung injury, I think from sepsis, but I can't remember clearly. And you can see this patient's got a tube in up the top there and an endotracheal tube. And you might actually see a very faint outline of a tube in there, which meant this breathing failure was so bad they had to be put onto ECMO. Anyway, that's right down the far end of the scale. Now, so we're now, of course, talking about hypoxemic respiratory failure. Now, oh, that slide is out of position. So there you are. But that is also to say that severe lung injury like that can also lead to hypoxic respiratory failure, can also lead to ventilatory failure. Now, we've spoken about acute can't breathe. Now I want to talk a little bit about chronic can't breathe. Now here there is a permanent load to breathing exceeding the power available to shift that load. And so these patients adopt a permanently abnormal respiratory pattern. Their CO2 goes up, and this is a fatigue sparing mechanism. In other words, they don't have to breathe so much. Their body gets used to the high CO2 and they don't fatigue their muscles as much because their minute ventilation is less. Because the CO2 has gone up, that means there's a higher CO2 concentration in each breath that you breathe out. So you're getting rid of the same amount of CO2 or V dot CO2, as I've written there, which is the mils per minute of CO2 being produced. You're getting rid of that same amount of CO2 with a much lower alveolar ventilation rate because it's got a high concentration. Now, of course, when your CO2 goes up, your pH goes down, and that is distressing because that your respiratory center says, I'm not happy with this, breathe more. So when your CO2 remains up all the time, your kidneys undergo what we call renal compensation, which I'm sure you're all aware of. And that is where they retain bicarbonate so that the pH is corrected. So that when you have the CO2 elevated for some time, instead of being acidemic and needing more or being driven to breathe more, even though you can't do it, then you have a pH that comes back up towards normal with a higher bicarb, and you don't have the same respiratory distress. So it's important to put some numbers on this. You're all familiar with the CO2 plus water produces bicarbonate and hydrogen ions equation. And we know, therefore, if the CO2 goes up acutely by 10 millimeters mercury, that's going to put the bicarbonate, the pH down because the hydrogen ions goes up and the bicarbonate up. And for every 10 that the CO2 goes up, the bicarbonate goes up by 1. So if your normal CO2 goes from 40 to 50, your bicarb will go from 24 to 25. Not much, but a bit. But the renal compensation puts the bicarbonate up by 4 for every 10 the CO2 goes up. So if you've got a chronic bicarbonate elevation, you come close to a normal pH. So if your CO2 goes up by 10, then your bicarb in chronic renal failure will go up by 4, and that will come very close to correcting your pH to normal, into normal range, and that will remove your respiratory distress. So let's just look at what we've said and relate it to blood gases. So if the CO2 is up and the pH is down, then you've got acute respiratory failure. And of course, we've already said that the bicarbonate will go up acutely by 1 for every 10 that the CO2 goes up. You then look at the patient, and they're either a won't breathe or a can't breathe. If they've got normal or low respiratory effort, then they're not interested in breathing. And that's a much more stable clinical situation usually. Just have to turn their morphine down or stop their sedation and they'll come good, usually without needing a ventilator. But if they can't breathe, they've got an abnormal respiratory pattern with a high respiratory rate and distress, then they've got ventilatory failure, and unless you can reverse something quickly, like severe asthma coming good rapidly with bronchodilators, they are at risk of needing ventilatory assistance. Now, if you look at the blood gases and the CO2 is up, but the pH is close to normal, then that's not acute respiratory failure. And it may be chronic respiratory failure, and I say may. So here, there'll be a bicarb elevation. Bicarb goes up a whole lot more to make the pH normal. And so it usually goes up by 4 for every 10 that the CO2 goes up. So again, we look at these people, look at this group. If you know they've got chronic lung disease, or if they've got abnormal respiratory action, low tidal volume, fast rate, but no distress, then they're probably a can't breathe patient with a chronic lung disease. If, on the other hand, they've got normal respiration, then it may be that they've got a primary metabolic alkalosis. And you may or may not know at this stage, but one of our most commonly used drugs, frusemide or Lasix, is very potent at causing a metabolic alkalosis. And so when you cause a metabolic alkalosis with a diuretic, then you do need to underbreathe a little bit. Now, in theory, the metabolic alkalosis patient will always still be a little bit on the alkalotic side because it's the alkalosis that's driving the CO2 to be up. And the chronic respiratory failure will still be a little bit on the acidotic side because it's the acidosis that's driving the bicarb retention. However, whilst that is correct in theory, it doesn't always work that well in practice because our ventilatory rate and CO2 levels vary too much from minute to minute. Okay, so how do we manage this? Well, like any, the axiom of medicine is to identify and treat the cause if possible. So I'm not going to dwell on the treatments of all the causes of respiratory failure, but obviously asthma, bronchodilators, pneumonia, antibiotics, sputum retention, physio and suctioning, pain, analgesia, foreign body, remove it, inflammatory lung disease, steroids, and CO2 production. You might want to lower the glucose feeding if it's too high. And if there's muscle force failure, then you can, due to relaxant agents, you might want to reverse the relaxants or antagonize the drug, such as giving Narcan for patients with too much morphine. So that's not what this talk is about. Now, the next step of helping ventilatory failure is to assist their breathing pattern with non-invasive ventilation. That is mask ventilation. So it can be nasal, and generally nasal ventilation is effective for sleep apnea, but it's not effective in acute respiratory failure. You've got to put the full face mask on. And so I want you to imagine it as like a charity. Give it generously. If patients got respiratory distress, or it's hard to get into trouble with non-invasive ventilation, with a couple of exceptions that I'll give you. But so it's worthwhile giving it generously if you can avoid intubation. Now, we particularly know it helps in exacerbations of chronic obstructive airways disease, or COPD. We know that it helps in acute pulmonary edema, and you may only need CPAP for that, but non-invasive helps for that. And any acute hypercapnia that's a can't breathe, not due to sedation, that where you expect it to come good in a short term. It is used for acute lung injury and ARDS, which primarily for hypoxia, but you shouldn't persist with this too long if the patient isn't getting better, because it's been shown now that if you leave people with this lung disease too long on NIV without intubating them, their lung injury can actually get worse because you're not inflating the lung as it should be inflated. So that's mainly in relation to hypoxic respiratory failure, but this group too can have ventilatory failure, which is why I've mentioned it here. So it's good for the middle three, and it's okay at the start of the acute lung injury or ARDS, but don't leave it on too long if you're not getting somewhere. Now, the next step is to intubate and ventilate if necessary. Now, the decision to intubate depends on the type of ventilatory failure, but also on whether the patient is coping or not, and the natural history of this illness. So that sounds complicated, but I hope I can explain it. It doesn't depend on the CO2. You don't say the CO2's 50, we don't need to intubate. The CO2's 60, we do need to intubate. So the CO2 is a factor, but it's the last step in your decision. So won't breathe. Too much morph and relaxant. CO2 65. Let's get rid of the relaxant there because that usually means they're not breathing at all. But let's say too much morphine or sedation with a CO2 of 65 may not need ventilation or even respiratory assistance, because if it's a stable breathing pattern, unless they've got more opiates to be absorbed from their gut or absorbed from somewhere else that you weren't planning on, they may not need ventilation. And if you just leave them, their morphine levels their opiate levels will go down and they won't need ventilatory assistance. If you think they might need ventilatory assistance, then of course you'll give the antidote to morphine, remembering that the antidote has a much shorter half-life than the morphine itself, so it won't last until they've recovered. But if, on the other hand, if they've got a head injury with a CO2 of 50, and it might be due to opiates, you do want to intubate and ventilate those patients, because the hypercapnia is bad for their brain. So you can see it's a different decision-making pathway, because the first line is going to get better with time. The next one might get better with time, but you're going to get the brain into trouble straight away. So you've got to do something about it immediately. Now, the next is a can't breathe. Now, if you've got an asthma or a flail chest from a car accident, and their CO2 has been going up while you're treating them, in other words, despite the outstanding nature of your treatment, this patient is progressing towards respiratory collapse. You really need to treat them. In other words, they're getting worse despite everything we're doing. They need to have breathing assistance, usually intubation. On the other hand, an asthmatic who has had an acute onset of asthma, let's say it's thunderstorm asthma, who hasn't had any bronchodilators, might have a CO2 of 100. You say 100, heavens, we have to ventilate that. But if you give him if he still doesn't look too bad, if he's coping, he might respond within an hour to bronchodilators. And so it's worthwhile holding off until that can get better. If you have, and often we've seen patients whose CO2s come progressively down and they've improved with bronchodilator therapy over 3 to 4 hours, and they haven't needed intubation despite that very high initial CO2. If you've got chronic obstructive airways disease with a CO2 of 60, it might be a little bit worse. It might be normally 55 and up to 60. If they're often more stable, and we avoid ventilation if possible. And as I said before, we might give NIV if they've got some respiratory distress, but try and avoid intubation. Now, what is our decision to intubate based on? This is primarily a clinical assessment. So we take into account all those factors about what we expect to happen. Are they going to get better or worse when we wait? But if we look at the end, it's the end of the bed assessment. If you can see somebody who's in severe respiratory distress and you don't think they're going to get better quickly, then don't leave the room. Be prepared to intubate them, or at least if you think they're going to get better quickly, be prepared to intubate them in case they don't respond to your treatment or you're not invasive. So it's a very important factor. If they're in severe distress, generally they're going to need help quickly, and often it's intubation. Also, it can be helpful asking the patient. So if you've had a patient who's been okay and you say, how are you coping? How are you feeling? And they say, Doc, I'm exhausted. Help me. I need help. I'm not making it. Then believe them. they're not saying that just to be attention seeking. That's a real, if they say they're running out of steam and they're failing, believe them. Don't wait till they've actually conked out. So that's an important part of the assessment. Now, the breathing pattern is useful. So if the breathing pattern is less than 4 or more than 40, then that's a severe, I can't see because the screens are there, what's the other number is, but whatever number I've got hidden there, more than 40. Tidal volume, I think, is less important. In other words, if their tidal volume, yeah, so if their tidal volume is not enough for them, they'll tell you that by putting their respiratory rate up to an uncomfortable level. And the last important point is the direction of change. If you're watching somebody and their CO2 is progressively going up over time and your treatment isn't actually preventing that, then that's a sign that you need to step in. If the respiratory rate is increasing, or if you are measuring in a case of a severe asthma patient, their peak expiratory flow or their FEV1 with spirometry, if that's getting worse despite your treatment, that's also giving you a message that they're going to need ventilatory support. So clinical pattern, most important, clinical assessment. Breathing pattern, also important, and the direction of change of very simple variables getting worse. Now, so that's ventilatory failure. Now, I want to talk a bit about hypoxemic respiratory failure. And this is where there's a primary problem of a gas exchanging defect in the lung, resulting in hypoxia. Usually, ventilatory mechanisms are normal. And so the CO2 in pure ventilatory failure, pure hypoxemic respiratory failure, CO2 normal, or the ventilation might be increased and the CO2 goes down a bit. Now, it's worthwhile looking here at the mechanism of shunt. So here we have our stylized lung. There's our venous blood coming in with a saturation of 76 and a CO2 of 46. And this saturation is improved from 70 up to 98% in the normal lung, or 100% say, and a CO2 of 40. And let's say there's a 50% shunt for mathematical ease, then the venous blood goes, 50% of the blood goes through with a saturation unchanged and a CO2 unchanged. The average of these two is a saturation of 85 and a CO2 that goes up to 43. So a shunt by itself causes both desaturation and hypercapnia. Now, the response is to increase ventilation. So when you increase your ventilation, that is effective at lowering the CO2, which corrects the arterial pH, but it's ineffective at increasing the saturation. In other words, putting the CO2 down here to 36 or 35 doesn't put the saturation up much at all. So it doesn't change the arterial saturation. That is why the shunt primarily causes hypercapnia, but if you respond to ventilation, if you have an increase in ventilatory ventilation in response to this, your CO2 is corrected. Now, the corollary of that, of course, is if you can't increase your ventilation, then such as when you're on a ventilator that's fixed, or when you've got severe COPD, then when your CO2 goes up as a result of a shunt, you can't fix it. So you do see hypercapnia with a shunt happening. Now, what's the etiology of acute respiratory failure? Well, you know all these things, so I won't dwell on it. So it can be a parenchymal injury or a vascular injury. Acute parenchymal injury, pneumonia, aspiration, pulmonary edema, ARDS, atelectasis, an occluded airway, airway obstruction. Chronic parenchymal injury, of course, pulmonary fibrosis, chronic bronchitis, COAD. Vascular injury acutely is, say, a pulmonary embolus, or chronic is chronic pulmonary hypertension. All those cause hypoxemia. Now, hypoxemia is usually not clinically obvious. You've got to have more than 1.5 grams of desaturated hemoglobin. So if you've got a hemoglobin of 15 and your saturation goes down to 90, that will show a little bit of cyanosis. But if you've got a hemoglobin of 10, you won't get any cyanosis till your saturation goes down to 85. So it's a kind of a late sign, and it depends on, and when it's mild, it's pretty subtle. So hypoxemia is usually not clinically obvious unless cyanosis is a late sign. And when it's really bad, you can get mental confusion. The ventilatory increase is quite variable. It depends on the severity of hypoxemia, depends on your ability to increase your breathing, and it also depends on your ventilatory responses. So there's underbreathers and overbreathers, and I won't dwell on this, but I'm an underbreather and others are overbreathers. In other words, when they get hypercapnia, some people hyperventilate a lot, I'm sorry. I don't increase my ventilation much at all. Underbreathers are good at breath holding and diving, but they'll never get to the top of Mount Everest because you need to be a hyperventilator in response to hypoxia to have enough air up there. But people with high ventilatory responses struggle more with breath holding and diving. So dyspnea in association with hypoxia might be obvious or not apparent at all. Most commonly, the clinical features are those of the cause of hypoxemia. In other words, we recognise the airway obstruction from wheeze, aspiration from vomiting, sputum retention from bronchi, pneumonia from bronchial breathing and fever, pulmonary edema from dyspnea and foaming at the mouth, and so on. So most times we recognise the cause of hypoxemia and then we do a blood gas or put a pulse oximeter on. In other words, we diagnose the hypoxemia secondary to the illness. So you've got to suspect hypoxemia from a clinical cause or an abnormal chest X-ray and put a pulse oximeter on. Pulse oximetry, of course, doesn't give you ventilation or acid-base information. And as you know, it's unreliable when you are shut down and shocked. Not enough blood flow to the fingers to give you a good pulse for the oximeter to read it. Blood gases are most reliable. They give you acid-base material, acid-base information. But of course, you've got to stab the artery, and that acid-base status only applies to that one moment in time, not the next hour when the pulse oximeter is on. And of course, you want to diagnose the cause, and that's usually based on, sorry, I'll keep flashing these slides, a chest X-ray and spirometry and a pulmonary angiogram if required. Now, of course, again, we treat the cause, and I'm not going to go through treating all the causes. And of course, we've got to correct hypoxemia. Initially, we just give oxygen. Then we might go to CPAP, BiPAP, or high flow, which should be on this slide. When that is not working, we intubate and ventilate. And of course, the prime things that we do to improve oxygenation on the ventilator are give PEEP, nitric oxide, lung recruitment, and prone positioning. And we give all those things in the reverse order of that. And finally, when all fails, when ventilatory support doesn't adequately fix the hypoxemia, we put patients on ECMO. So now I'm just going to talk a tiny bit about the different diseases we ventilate people for, and then we're going to open it up to questions. So 90% of mechanical ventilation is for one of three reasons. Firstly, or one of three lung reasons. One is normal lungs. Why do we ventilate people with normal lungs? Because they've got another problem, like they've taken a drug overdose, or they've just had an operation, or they've had a car accident and they've got a head injury. So, and these patients generally have a high oxygen level compared with their inspired oxygen. That's a PF ratio of greater than 300. Or they might have a lung injury, which can be from multiple causes, or they might have airflow obstruction. And there are three different ventilatory strategies. So this is just a slide looking, and I'm not going to, a meta-analysis looking at low tidal volume for normal ventilation. We used to say, give a big tidal volume, it reduces atelectasis. We now know that big tidal volumes, that is more than 7 mils per kilo, in fact, injure normal lungs. When you're in ICU, your lungs aren't really normal when you're on a ventilator, they're just relatively normal. But we know big tidal volumes compared with small tidal volumes cause more lung injury, more lung infection, more atelectasis, and actually are associated with a higher mortality. So we've certainly know that lower tidal volume ventilation is important in normal lungs. Now I'm moving to lung injury. And this is an animal model experiment that was done, I can't do the math, 40 years ago, 45 years ago. And that's where they took normal lungs in an experimental model and ventilated them with very large tidal volumes here. And they found that these lungs got a lung injury with hemorrhage and edema, very similar to ARDS. This is just from ventilating the lungs, pardon me, to a much larger volume than they would normally go to, which is over 30 centimetres. So big tidal volumes, overventilation can cause lung injury. And interestingly, if you put them on PEEP, despite giving the same big tidal volume, which is injuring the lungs at a high pressure, you get less, it's still edematous, but not so much lung injury. So this is an incredibly important experiment that was largely ignored by intensive care for about 25 years. And, but eventually it was shown that we found that, and this is CT, looking at a CT of lung injury, that the lung was in 3 zones. The most dependent zone that remained collapsed throughout tidal ventilation, the least dependent zone that received all the tidal volume, and a zone in the middle that collapsed and re-expanded with each breath. And so in fact, we were putting a normal tidal volume into a much smaller lung. So we're in fact overstretching this much smaller area of lung, and that was causing lung injury. And this intermediate zone here was in fact, was collapsing and re-expanded with every breath, and that was causing tearing between alveoli and giving them PEEP, kept them inflated, and so they didn't, there was less shearing force injury. Now, this looks like a lot of cytokine information. It looks pretty boring, but TNF alpha, interleukin 8 and interleukin 6 are the cytokines associated with multiple organ failure in critical illness. And if you use unsafe ventilation with big tidal volumes, all these things are elevated. And if you use protective lung ventilation, all these things are low. And so we now know that protective ventilation, and this is a very early study, had a much higher survival rate than conventional ventilation. I'm skipping through this because we're running out of time, but and when there was a large trial done in the States with low tidal volume, there was a much also reduced tidal volume in this, reduced mortality. And there was much lower mortality, mainly from less multiple organ failure. So we thought that lung injury and extrapulmonary injury caused the lungs because they were first and worst in filtering the venous blood. This was associated, but not with multiple organ failure, and that's what led to death. So 2/3 of deaths in ARDS come from multiple organ failure. We now understand that the mechanical ventilation itself can actually make the lungs worse. And so we actually can cause a lot of this lung injury, not just these conditions over here. And secondly, we now know that the lungs can in fact produce injurious cytokines that make the other organs fail, and that too can lead to an increased mortality. So improving mechanical ventilation leads to a lower multi-system failure rate and a lower death rate. And that's where there's been a huge focus in the last 20 years on improving mechanical ventilation. Now, I'm not going to dwell on this long, but basically safe ventilation is small tidal volumes, 6 mils per kilogram or less, with a pressure well under 30. And higher levels of PEEP 15 up 10 up to 15 to prevent collapse re-expansion. And this does not expand this most basal segment. And we now know that prone ventilation is effective expanding this, and this also reduces mortality. So they're the three main things we do to reduce lung injury from ventilation. So I'm going to skip that and just speak quickly about asthma, and then we'll stop. This is a patient who was nearly killed from asthma ventilation. You can't see, but there's severe bilateral pneumothoraces because the lungs don't collapse, but they have high degree of tension. You can see those little arrows there showing off the lung edge that you can't see, because there's a massive degree of tension there because the heart looks like a sardine in the middle of the chest. And you'll notice the left hemidiaphragm is completely inverted. There's such a high tension there. So this clearly is a life-threatening event. And we know that a lot of patients with severe asthma who are ventilated, in fact, do die. And we understand that in our early part of mechanical ventilation, that a lot of their deaths were also caused by mechanical ventilation. And there's this simple thing that I want you to understand, and that is that when we ventilate normal lungs, this is the lower graph, normal or stiff lungs, which is what we do most of the time, the air goes in and it all comes out before the next breath arrives. In, all out. And the lungs return to their passive relaxation volume, or FRC, functional residual capacity. This is not true in obstructed lungs. We put the air in, might only be 2/3 out, in 2/3 out, in 2/3 out. And so there's a bit of gas trapping with each sequential breath, and the lungs get bigger and bigger. Now, this does not happen until the patient fills the whole cubicle. It is self-limiting. In other words, the lungs go up to a volume where the amount of air that's put in actually comes out during the expiratory time available. Just getting a phone call there. And that is because when the lungs get bigger, the elastic recoil pressure increases, and also the small airways, which are in the lung parenchyma, get bigger. So it's an adaptive process. If you've got mild airway obstruction, you can't get the air you need at a low volume, but you can at a high lung volume, even though your respiratory muscles are weakened by that process. But on a ventilator, this process, if we give too much ventilation, can drive the lungs over total lung capacity and cause respiratory tamponade and pneumothorax. And so here we are. When you are spontaneously breathing, you breathe your way all the way up to total lung capacity. But when you're on mechanical ventilation, we can easily make the lungs go bigger because the ventilator is just concerned with putting air in. It doesn't worry about what does or doesn't come out. And if you take a breath out, you can see the lungs will empty out down to their elevated FRC and fill up within the next 10 breaths. And this is the last slide I want to show here. And that is a patient with severe COPD. And here's the wedge pressure and the esophageal balloon. There's the cardiac output. And the patient's hypotensive on the ventilator. When the patient was taken off the ventilator and allowed to breathe out for about 40 seconds, the wedge pressure in the pulmonary artery catheter came down, the esophageal pressure came down, and the blood pressure came out. The heart had been let out of jail. The lungs deflated, the heart wasn't being squashed, and the cardiac output could go up to normal and the blood pressure to normal. The moment the patient was put back onto the ventilator, the lungs reinflated in that stepwise pattern that I've shown you in the last two slides, and the blood pressure came down again, the cardiac output went down again. So that's the problem with ventilating asthmatic lungs. You've got to be very careful that you give a low tidal volume and a low rate. And we will finish at that point. So respiratory failure type 1 and type 2, quite different mechanisms and treatment. The intubation decision is clinical. Ventilation must suit the lung pathology. We need to avoid ventilator-induced lung injury, which is now a primary consideration in ventilating patients. And we didn't talk about it, but we've also got to look out for ventilator asynchrony. So I'm sorry I've gone a bit over time, and I'm open to questions.
Thank you so much, Prof. Tox. Prof. Tuxton. I think we have some questions coming through the Slido. We'll just share that.
Yep.
Yep, I'm just sharing that now.
Thanks, Matt.
Can I get you to stop sharing, please, David?
Yep.
Thank you. Okay. So, just excuse me while I get this up. Sharing screen now. All right, here we go.
Okay, so I think the first question is periodic breathing the same as Jane Stokes breathing?
Jane Stokes breathing.
Yeah.
At first glance, it is, but of course, they're quite different origins. And the periodic breathing is of course respiratory in origin, and they have a much more cyclical phase from hyper to hypoventilation. Jane Stokes is of course neurological in origin, and they often have periods of much more, shall we say, unphysiological hyperventilation, gasping breathing, followed by apnea. So the periodic breathing looks a lot more regular, whereas Jane Stokes looks a lot more asynchronous, if you like. But they are alternating hyper and hypoventilation, so they are easily mistaken unless you look at the pattern quite carefully. And of course, different cause. How does a shunt occur? Should I do that one?
Yes.
Yes. So a shunt, of course, we mentioned that increased dead space is a lung that is ventilated but not perfused. So that means the air goes in, but there's no blood supply to that lung, so it doesn't add any oxygen or take any CO2 out. A shunt is the opposite. That is an area of lung that is perfused but not ventilated. In other words, let's say, imagine a whole lobe of a lung completely consolidated with pneumonia. That means the venous blood arrives and goes through and doesn't have any oxygen added or any CO2 taken out. So that's a shunt, and I should have explained that. So my apologies. And it can happen from it might be something as clear as a lobe, or it might be a diffuse lung disease where there's little bits of lung here and there all over the lung that are shunting blood. In other words, there's bits of lung that have no air going in and out, but blood going past them. So they don't do any gas exchange on that blood that goes through them. The lungs do compensate a little bit for shunt, and just like there's hyper and hypoventilating trends, high responders and low responders, we have lungs have high and low responders. In other words, some people have effective vasoconstriction in a shunted area, so less blood goes through the hypoxic area, and others don't have that mechanism that works as well. So they get much more blood flowing through the pneumonia lobe. So their shunt causes more hypoxia than it would in another patient. Is there a role for opioids in ICU? Yes, there definitely is. There's no question that that opiates reduce respiratory distress, and so they reduce respiratory muscle fatigue, and they can have a slight vasodilatory effect, and that also can help. So it can be used to treat respiratory distress, but it's got to be in, the biggest mistake you can make is say, here you are, you've got respiratory distress, I'm not going to support your ventilation, I'm just going to give you opiates and I'll come back in half an hour to see how you are. That's absolutely what you don't do. But if you've got somebody under constant observation and getting support for their ventilation, such as NIV, then or high flow, then certainly opiates can help while you're waiting for their for a resolution of their clinical problem. Hi, could I explain ECMO in further detail? Happy to. So ECMO happens, let's say we've got a patient who comes in. There's two kinds of ECMO, but we'll just talk about the one for respiratory failure. A patient who comes in with severe lung injury. It might be severe bilateral pneumonia, and we do the very best we can with antibiotics and drying them out and circulation supports, and we put them on the highest PEEP they can tolerate and the highest inspired oxygen, and we prone them and do everything. And sometimes these patients still have a saturation in their low 80s, despite a very high PEEP and everything we can do. And they're on a downhill path. We say, gee, they're probably going to die. And so in this circumstance, we put them on ECMO. That is, we put 1 or 2 large venous cannulas in their femoral veins. And we take blood out of one, the most distal cannula or cannula port, and it comes out and it goes through an oxygenator, which puts oxygen in and removes CO2. It's like an external lung. The oxygen is run through at varying flows. The amount of oxygen determines how, well, generally it oxygenates to 100%, and the gas flow determines how much CO2 is removed. So the lungs don't have to do as much work, and it's got a flow similar to cardiac output. We try and get 4 to 5 litres. And that can keep, so all of a sudden the venous blood returned to the more proximal, the line that's closer to the heart. The venous blood arrives to the lungs with most of the CO2 taken out and most of the oxygen put in. So that patient's lungs can be contributing nothing, but they will be kept alive with oxygen being put in and CO2 being removed as a result of the external oxygenator. So that's veno-venous ECMO, which is used for respiratory failure. We also do, and that's of course in a patient with a normal cardiac output. In other words, there's enough flow through the lungs and around the circulation to deliver that oxygenated blood. The other type of ECMO is a veno-arterial ECMO, and that's not used for lung failure, but for cardiac failure. In other words, let's say somebody's got an end-stage cardiomyopathy and they're waiting for a lung transplant, or they might have an acute cardiomyopathy that we think might get better or might go to lung transplant. We put them on veno-arterial ECMO. That is a cannula that goes into a large femoral vein and into the femoral artery. We take blood out of the femoral vein and put it back into the femoral artery. So the blood is completely oxygenated, has the cardiac output removed, but also it gives a flow into the arterial system of 5 litres a minute. So even though the heart is failing to deliver enough cardiac output to keep that patient alive, they don't need to do this. And I've seen this happen, just to digress you, in a young 32-year-old man who becoming sicker and sicker and sicker at home. He couldn't even walk, couldn't even get out of bed. He was becoming tired and exhausted. And he came into intensive care. He was lying on the bed. He wasn't put on a ventilator. He was just on a few inotropes. And while he was sitting there at rest, watching the cannulators, they cannulated his femoral artery and femoral vein. And within 15 minutes was all done, and he felt terrific. And I've got a photo of him half an hour later, or an hour later, I think, eating a McDonald's burger as he sat in the bed. So that was extraordinary. So that's ECMO. It stands for extracorporeal, outside the body, membrane oxygenation. That means the blood's passed through a membrane and it gets oxygenated and also gets CO2 removed. But ECMO, extracorporeal membrane oxygenation. Looks like we're all done. Is that all the questions?
Yeah, I think that's all the questions for now. So I think we'll leave it there. Thank you so much, Prof. Tuxen, for volunteering your time. I think we can all take away so much from that, whether it be approach to respiratory failure, mechanical ventilation, a little bit of ECMO too. I'd like to thank everybody for also coming. As usual, the event is recorded and will be uploaded to our YouTube page. And look out for our next upcoming ICU webinar on fluids and electrolytes next week. But yeah, thank you everyone for coming out, and enjoy the rest of your evening. We'll leave it there. See you guys.
Thank you very much. It was good fun.
Thank you, Prof. Tuxen.
Thanks very much.